My name's Rebecca Haffajee. I'm an assistant professor of health management and policy at the University of Michigan School of Public Health. I'm both a lawyer and a health policy and health services researcher. And what I focus on now is evaluating behavioral health legal interventions. So things like opioid misuse prevention laws and policies, and try to code variation and categorize variation across jurisdictions, especially across states, and how they're approaching these issues, and then infuse that into a more traditional health policy evaluation to see if differences in policies are making and having an impact on health outcomes, healthcare utilization, healthcare costs, those sorts of things. I think the largest public health challenge that our generation is facing and will face for the foreseeable future. We have 33,000 deaths per year in 2015. This cause of death has surpassed that of motor vehicle injuries, gun deaths combined. So it's the leading cause of injury death in the US. It's also the leading cause of death among adults, middle-aged adults in the US at the moment. So this is, motor vehicle injuries have been the leading cause of injury death for a long time in the US. So in 2008, when these types of drug poisoning deaths surpassed those, that was really a pivotal moment where, we had a switching of, what are the leading causes of injury deaths in this country, and they've only continued to climb. These drug-related deaths and specifically opioid-related overdose deaths, which account for about 2/3 of those drug poisoning deaths. And we think that they're still rising. That's the most concerning thing. They've been climbing throughout from 1999, 2000, continuously through 2016, which is the latest year for which we have estimates. But even in that most recent year or two, those climbs, the slope has steepened. So it's actually getting exponentially worse and attributable largely to some of the illicit sources of opioids now, particularly the fentanyl, carfentanil, and those analogs that are particularly potent, are 50 times more potent than heroin, for example. And so, you take much less and are much more likely to overdose and have a death result. And it's harder to reverse that overdose because the substances are so strong. It was really a confluence of events because this is actually the third opioid epidemic of sorts that we've had since the 1900s. We had, one related to opium and then another related to prescription opioids earlier in the century. And so, those were significant, but not nearly of the magnitude that we have now. And I think a number of factors contributed to the severity of this particular epidemic. So we had a number of things. So one was this shift. The pendulum has been swinging again through the 1900s in favor of aggressively and more proactively treating pain, and then swinging back to ratchet back on the opioid prescribing of painkillers for that treatment. So we've been kind of swinging back and forth. And in the 1980s and 90s, the pendulum was swinging towards treating pain more aggressively. So the American Pain Society adopted pain as the fifth vital sign. That was also adopted by the Veterans Administration and the J-Code, the Joint Commission that accredits healthcare organizations. And so that really, created momentum. There was, a lot of thought among physicians and among prescribers that we weren't adequately treating pain. And then at the same time, opioids emerged as a prime candidate for treating that pain, largely pushed by a couple of factors. There were a couple of medical journal publications. Most key was a publication. It was actually just a letter to the editor in the New England Journal of Medicine, which is the most impactful medical journal in our country. And it was an anecdotal letter of a couple sentences that suggested that in certain physicians' observations that patients were not as prone to addiction. So, and it was, very small sample size. It was not a peer-reviewed, rigorously conducted trial. It was, merely in our observation, this small percentage of patients get addicted. And then that has now since been cited over 600 times in other medical journal articles and other literature. This, was unfortunate because this was, again, not peer-reviewed. It was not robust science. And actually, the message was adopted. There were other physicians. Russell Portnoy was one who really were front men for advocating the use of opioids for treating pain, including chronic pain, for which there was not a good evidence base that it was effective, that it was non-addictive, and much of this was funded and supported by the drug industry. And there was aggressive marketing, particularly notably by Purdue Pharma, of OxyContin, a very strong painkiller from 1997 to 2002, approximately. So that was another factor. So that was happening, and there was a lot of detailing that was happening for physicians to promote the use of these opioids for chronic non-cancer pain, for which, again, there was not a good evidence base. And FDA, at the same time, had approved these substances based on short-term clinical trials and using endpoints such as pain and sort of a single or maybe two clinical trials, and not kind of considering the longer term impacts and looking at addiction, for example, as an endpoint. So we didn't really know a lot about that, and that hadn't gone into the approval process. So we had these approved drugs, we had the drug industry pushing them, we had, promoting of treating pain for, to address patients' issues. And then all of that was happening at the same time. And so I think that really created a culture among prescribers to actually use these drugs as the go-to and prescribe them in increasing and vast quantities. And now we're at a point, we consume 80% of opioids in this country, but only have 5% of the world's population. So you can see there's a huge differential in terms of how much we're going to these drugs for treating particularly chronic pain. And we are aware, though, now that many patients do, when they get more than 5, 7, 30-day prescriptions, they then can go on to become chronic and long-term users of opioids. And so there are risk factors there, too. And so we're thinking about how to appropriately treat acute pain and limit the amount of opioids. But I don't want to argue that there is no role for opioids in our clinical practice and in medicine. They are effective in some contexts, and particularly acute pain, post-surgery, for example. But really, on the chronic side, there is still not a great evidence base. But one of the challenges is we don't have a lot of therapeutic alternatives. There are a number of legal and policy approaches that we have both adopted or are available to address the opioid epidemic. I would say most of the activity has happened at the state level and among localities thus far. So at the state level, we've had, I think, probably since 2010, close to 1,500 bills introduced related to opioids, and probably close to 500 have been adopted and enacted. So that's a lot. And so states are, I think, scrambling to some degree and trying to enacting a lot. And we're trying to evaluate as quickly as we can what's working. And a few leading policies have emerged as potential tide changers in the opioid epidemic. So one is one that I study, that's prescription drug monitoring programs. The use of these databases, they started out as law enforcement databases, but then shifted and morphed into clinical databases. Again, these aggregate all of the controlled substance prescribing, or most of it, at the state level. And so the idea is that a prescriber would log into the system as they're, before or as they're seeing the patient, see what their history is of controlled substance prescribing, for the past year or two, usually is in the database, and know, has this patient been frequently obtaining and filling prescriptions for opioids in the recent past? Are there potential polypharmacy concerns? So that would be drug interactions. One particular interaction of concern is with benzodiazepines, because that combination of benzodiazepines and opioids is a high risk factor for overdoses. So it's sort of a full picture of what the patient has been getting on the drug side, that all of that information would not be available within an electronic health record or electronic medical record, because that would typically be only the provider and that system level database, and not all of that information is being shared among providers within a state. Also, in the prescription drug monitoring programs, or PDMPs, I'll call them, there is sharing of data across states increasingly. So if patients are traveling across state lines to try to fill opioid prescriptions in another state, that would be captured with increasing frequency. But we've identified some policy levers for first that get prescribers to actually use the databases. So use mandates that require that they check the databases under pretty comprehensive circumstances. For example, when they're seeing a new patient, when they are prescribing opioids for chronic pain, every 3 months they have to check it. So a number of states, about almost half now, have some kind of a use mandate, and that's, has some comprehensiveness to it. And that we've shown actually does reduce opioid prescribing, does reduce overdoses. So that's a effective policy lever. We do know that 4 out of 5 heroin users, for example, did start out with prescription opioids. So some of these state level interventions that I'm talking about, like PDMPs, also regulating pain clinics that prescribe painkillers as a main portion of their business, those are two state features that seem to have really contributed to this reduction in opioid prescribing. It's still high because it's still 3 times the level that it was in 1999. So we still have a ways to go, and there's a lot of variability. So some states have 6 times the prescribing of other states by most recent estimates. So we still have a problem there, but what we're actively researching now is how much are some of these policies that have contributed to reductions in prescribing contributing to this spike in heroin use and fentanyl use and overdose deaths that related thereto. They're defined typically as those that more than half of their business is prescribing painkillers to treat pain. So that's their bread and butter, essentially. A problem in a number of states, and states regulate them differently, was that some of these pain clinics had a medical director in name, but that physician was not on site regularly. They were not doing regular medical histories of patients, regular examinations. They also are often cash businesses. So, you hear these stories of lines out the door of patients that had $50 and were, seen for 5 minutes and then getting their prescription opioid filled on site, and then they would have it. So there was, I don't know the exact estimates in terms of the density across states. I know some states like Florida, Texas, I think Oklahoma had high densities. And some states have had quite a bit of success in regulating these pain clinics more closely. So the regulation would take the form of often requiring that the medical director be, on site a certain percentage of the time, that regular medical examinations are taken, and doing inspections regularly to make sure that some of these, regular medical practices that should be taking place are actually taking place in these clinics. So yeah, they were typically kind of outside of the realm of normal medical practice, again, cash businesses, and sometimes popping up as, sometimes changed, but often just one-off, operators. And so there's been some success, though. Florida, for example, regulated their pain clinics. They strengthened some of those regulations. They went in and inspected them. The DEA, the Drug Enforcement Agency, our federal agency, also is surveilling these pain clinics and goes in and investigates them often also. So they also came into Florida and helped in checking out these pain clinics. There were over 1,000 pain clinics in Florida, and they were shut down. It reduced to about 400, and they saw dramatic reductions in opioid prescribing thereafter. So I think that was, a pretty strong policy lever that we used in Florida to get the prescribing in Florida was like off the charts. It was by far the highest state in opioid prescribing, and that really contributed to reductions there. Texas also saw some effects from regulating its pain clinics more closely. So, because we have such a complex epidemic on our hands, it's hard to know where to start, and we have lots of recommendations and potential policies floating around. And I think, in my mind, it's important to differentiate those acute steps and what we need to take in the short term from longer term structural changes that are also needed. The president declared a national emergency recently, and you know there weren't specific, and to my knowledge, there haven't been specific steps or changes that have been taken pursuant to that emergency. It seems mostly symbolic at this point, especially given that the way it was declared, there are no funds behind actually implementing any of these changes. So I think step one is allocate billions of dollars to the Public Health Emergency Fund so that we can actually fund things to do on an emergency basis. Step two is differentiate what are emergency steps that we can take using those powers. And so, in my mind, the predominant one is going to be funding from the national government to the states, the provision of naloxone, the opioid overdose reversal drug that we just need in much higher quantities. And then, beyond that, we want to be thinking also along the downstream measures, providing medication-assisted treatment therapy and evidence-based effective treatment that includes drugs and therapy to as many patients as possible. We know that the treatment gap there is significant. At least 3 million people have an opioid use disorder, which means they're addicted or dependent and in need of treatment. And only, by best estimates, probably less than 1 million of those, or by other estimates, 25% are getting some kind of treatment. And of those, many are not getting evidence-based treatment. So there's a huge gap, and we need to provide that treatment in greater volumes and get people to start using it and availing themselves of it. So that would be the next step in my mind. And then beyond that, we've done a fair amount on the prescribing side, and as I mentioned, we've seen reductions in the overall prescribing of opioids. We still have further to go because there's variability in the rates of opioid prescribing still across the states. And so getting the messages out around the Centers for Disease Control, the prescribing guidelines for chronic pain, prescribing opioids for chronic pain, and really making that part of institutional medical practice. And other, there's been some proposals that other certain specialties should enact or propose these types of guidelines because opioid prescribing will vary across specialties, but really infiltrating that into medical practice more, and other things that I mentioned, like requiring that I think a mandate is called for that prescribers actually check these prescription drug monitoring programs and use the information to inform their prescribing. And then a number of states and the federal government, or actually CVS, actually just enacted a policy that for acute opioid prescriptions, there's a limit to 7 days, and some states have 5 to 7 day limits. And then after that, you would have to go back and you could still get your next prescription filled, but you would have to actually get a second prescription from the doctor. And obviously that adds some barriers, but I think just having more oversight over these drugs and not just giving out a 30-day prescription without checking back in and making sure that the patient is using the drugs appropriately. So those would be the package of interventions that we need to do. But one last thought is that we do need to think about some of the structural determinants of how we got here, and FDA is doing a lot more, and I think they're on the right track now. I think they were somewhat asleep at the wheel, but now are being more aggressive in terms of post-marketing surveillance of opioids and making sure that they're using addiction as an endpoint in their approval process and pulling drugs from the market if they actually do have addictive outcomes. So they seem to be, more proactively regulating opioids now than they certainly were for the last decade or two. So that's positive. But we also need to think about the socioeconomic and structural determinants, I guess you could call them, of the epidemic. So people, we know that people, you know, in some of the areas that are heavily affected, there are housing and unemployment, a lot of sort of life challenges that people are facing, and so trying to address those both for people who are first being exposed to opioids, but also those who are trying to recover, who are addicted, and providing those social supports. Because I think these medication-assisted treatment therapies, naloxone, and even opioids for treating pain, they all can be effective drugs in different contexts. But I don't think that drugs are going to drugs. They got us into this quandary. I don't think they're going to by themselves get us out of it. And I think we need to think more broadly about how do we create an environment where people don't feel that they don't have a propensity to get addicted to opioids, and don't need to turn to them for treating their pain, and then also, if they are addicted, have an opportunity to actually recover. So, with a national public health emergency, there are two mechanisms whereby that declaration can be made legally. The first is under the Stafford Act. That's what accesses the FEMA fund, which is quite robust. It's about $4.3 billion, and I think more is going to be appropriated soon. And that's what we typically think of, when we have our hurricanes, for example. The other mechanism is the public health emergency under Section 319 of the Public Health Services Act. You can think of that, actually, it's the Secretary of Health and Human Services technically that makes that declaration upon the recommendation from the president. But you can think of that as unleashing HHS, or Health and Human Services powers, and accessing a public health emergency fund, which is a separate fund. Was established in 1983, and it was supposed to be re-upped with $30 million every year, but that hasn't happened since the early 90s, and so now the fund is virtually empty. There's $57,000 in it. So what happened was the president in August said he was going to declare a national emergency. He didn't officially do so. And then what we were told was the administration was trying to figure out what was the best way, mechanism of these two with which to declare the emergency. You have to consider that there isn't a lot of precedent here for this kind of a national emergency or public health emergency. We usually reserve those powers in the public health sphere, at least, for infectious diseases, sometimes the hurricanes and the health effects that come from those, H1N1, those are the Zika was a public health emergency. So these kinds of acute conditions or diseases that we think of these powers as they're necessary to address acute harms and imminent harms, and we can't do so using normal legal means. So we need to harness these immediate powers. With the opioid epidemic, it's tricky, right? Because we have, and a number of states have, 6 states have declared opioid emergencies also using their state public health emergency powers. But it's tricky because it's a chronic health condition now, this issue of addiction. It's a long-term, long in the making and long in the getting out health epidemic. And I think epidemic is certainly the appropriate term. And so the question is this the right legal means and powers to wield to address this kind of an epidemic? And people differ. I personally think that now, because of many of the acute harms, particularly the fentanyl deaths, that it is appropriate to use these powers, but that they should be targeted towards those acute harms, and having a goal of avoiding X number or percentage of those deaths that are happening, and then once that hump is passed, that then the emergency is over, and then we use normal legal means to address the other harms. So what happened was, essentially then on October 26th, the president decided to declare a public health emergency, accessing that empty public health emergency fund, as opposed to a national emergency under the Stafford Act. So the difference being, you could think of it as being downgraded to some degree. There are not as many funds accessible. There are not as many powers that can be wielded, just the HHS powers. And, HHS can do some things, but it mostly has to be budget neutral at this point because they don't have any funds with which to do anything. So yeah, so I think a couple of things we can do now. Congress could appropriate a significant chunk of money to that fund quickly. And we are hearing that might happen by the end of the year, but not certain. But that would need to happen first, I think, before any really significant steps can be made. And then, there are certain powers that HHS could harness, like adding naloxone to there's a stockpile of drugs that are available, and then dispersing that to the states, and some other more nuanced HHS powers. The other thing that could happen, and that happens in a lot of other emergencies, is actually both mechanisms are triggered simultaneously or in short succession. So if the president also declared a national emergency under the Stafford Act, now, then we would have two of those, both emergencies happening at the same time. And then actually some other powers are unleashed. For example, we can, under HHS, we can waive certain program rules under Medicare and Medicaid. And so we could provide those services under those plans to populations without requiring documentation that they actually are beneficiaries. There are actually some more significant powers that could be unleashed. So I think those two strategies would be the ways that we can make this declaration more than symbolic. One would be just under the public health emergency, getting more money so we can do more stuff, particularly in terms of supplying naloxone and maybe medication-assisted treatment therapies. The other would be to very quickly declare a national emergency under the Stafford Act, and then we would have access to that FEMA fund also and unleash some other powers. So it's still very questionable in my mind whether this is going to be a meaningful public health emergency declaration. And also, from a legal perspective, because I think about that, setting a good precedent for use of these powers.